Hi everyone, this is Dr. Leong Hoe Nam here from the Rophi Clinic. This is another session where we try to make science simple and relevant for everyone. Today we're going to talk about COVID-19 antibodies. I received many queries from patients asking about the different kinds of antibodies. They are really all confusing. What is protective and what isn't protective? And though I like the antibody test, I just want to caution everyone that it's not just the antibodies alone. There's a very crucial component called the T cell arm. And we seem to have forgotten that these B cells and T cells, they work together to protect us from the COVID-19 infection. To understand the different antibodies against the virus, we really need to understand the structure of the virus, and you see this in the cartoon here on the left of the diagram. First and foremost, we actually have the single-stranded RNA. RNA, ribonucleic acid, this is how the genetic material is stored within the virus. It decides how many spike proteins you get, what's the structure of the spike proteins, etc. It is literally the RNA, the nucleic acid, formation of the virus. So the comparison is actually the DNA in humans. You have double-stranded DNAs, and this is how we code for ourselves. Do I have black hair, black eyes, etc. So the RNA and DNA in comparison, the RNA has a lot more mutational risks. So it likes to mutate a little bit more, and this gives it an advantage to try to adapt through mutation. On top of that, the virus only has single-stranded RNA, whereas in humans you have a double-stranded DNA. Double-stranded DNA, there's a check-back system so that big errors do not occur. But in the single-stranded RNA, you can have big errors occurring, and yet the virus can tolerate. Yes, you do have a disadvantage because you lose a lot of viruses because many of them could be catastrophic mutations. But given that there are so many ongoing proliferations at any one point in time, this becomes an advantage rather than a disadvantage. So besides the single-stranded RNA, you have the nucleocapsid protein. Nucleocapsid protein was discovered in 2003 to be the predominant protein. Lots of protein, lots of excretion, and if you want to do what we call the rapid antigen testing, you look for the nucleocapsid protein, you're more likely to detect the virus. And because of the work done in 2003, scientists have started using the nucleocapsid protein as the preferred target protein to try to detect the virus. So this is the target, and this is how most of the lateral flow or the rapid antigen testing are done. Now, besides the nucleocapsid protein, we have the spike protein. The spike protein exists on the outside, and if you look at it on the electron microscope, it does look as if the virus has a crown. Hence the name coronavirus, the virus with a crown. Now, the spike proteins are especially important because it decides how the virus interacts with the human cell. It has to bind in with the receptor, which is incidentally the ACE2 receptor. When it binds in and interacts, then the virus can enter the human cell. If you can block this interaction, you actually block the virus altogether. The immunity against the virus will thus be preferentially against the spike protein. And indeed that's the case. Spike protein immunity, antibodies, is responsible for about 90% of immunity against the virus. So if you can target the spike protein, you're actually replicating what the human system is doing in immunity. There are other proteins that create antibodies that can help to neutralize it. And this would be in the form of the M proteins, the nucleocapsid protein, for example. It takes up about 10% of the immunity against the virus. But at the end of the day, the key protein that stimulates the immunity is actually the spike protein. And you can thus imagine all the assays which try to measure the immunity against the virus would actually target the S gene. They do not target the N gene, but the S gene. You can block the S gene, you can actually block the virus effectively. Now, this is a very simple diagram actually showing you how the spike protein interacts with the human cell receptor, and then when it interacts with it, the cell accepts the virus and the virus penetrates into the cell. What you really want to do is antibodies that block this entry. Now, there's a beautiful YouTube video which you can watch. I put the QR code here on the screen and the link down in the comment section. Please look at it. It is beautifully done, and you can see how the virus ingeniously enters into the virus. It's a video worth watching. If you go to a clinic and ask for antibody testing, they'll ask you, what test would you want to do? There's the regular testing as well as the neutralizing antibody testing. The regular testing represents what we call the anti-S, and the neutralizing is the one which blocks the binding. So I'm going to show you a cartoon to try to illustrate this point. You have the spike protein here, and among the spike protein, you will bind to the spike proteins, all angles of it. It could be at the top, bottom, left, right, everywhere. But some of the antibodies bind to the area where they interact with the receptor. And you see the receptor as the ACE2 receptor here. You realize that the antibodies that's black in color will prevent the binding of the spike protein against the human's ACE2 receptor. When that happens, the virus cannot enter the virus and it becomes a blocking antibody. So most of the antibody usual testing, for example by Roche, Abbott or Siemens, you would actually measure all the antibodies, be it the black or the red ones. In fact, they will also measure the IgM or IgG, IgM being the earlier form of antibodies that are formed, or IgG, which is the later form. But in the case of coronaviruses, most of the time it is still IgG that's formed. But you realize for the neutralizing antibody test, like the cPASS for example, the black antibody blocks the binding. When it blocks the binding, it actually neutralizes the virus. Hence, we call this neutralizing antibody test. So again, two differences, anti-S, which are offered by Roche, Abbott, and Siemens, as well as the neutralizing one, which actually does the blocking. And because of this, the reporting structure is different. The anti-S measures it in terms of quantity, the number of antibodies there are. They actually give you a figure, could be 20, 40, 2,500, or even 5,000. In the case of neutralizing antibodies, it tells you the number of receptors which failed to bind with the virus. So it reports to you in the form of a percentage. All of us are familiar with this antibodies test, and it is really cheap. We like it. It's very easy to do it. Anyone can be trained to do it. Really, really simple. In fact, the test which you have down there in the picture is what we call a lateral flow test. You kind of drop one drop of blood at the well and then allow it to run, and immediately you have your antibody test result. But of course, in this situation, it only tells you positive or negative. It doesn't quantify for you. I guess you can do a semi-quantitative if you can actually measure how strong the signal is. But again, simple, easy to run, and many companies know how to make good lateral flow or antibody tests. These antibodies help us assess how effective we are able to neutralize the different variants and mutants there are. In this slide, we took it off the Pfizer-BioNTech press conference where it tried to look at the 2 doses versus 3 doses of the Pfizer-BioNTech vaccine and how effective they are in blocking off Omicron. So immediately on the x-axis, you notice the different strains there are. When I say ancestral, I refer to the original virus that was first isolated in Wuhan, China. Subsequently, you have the Omicron, Beta, and of course, the Delta strains. The y-axis will tell you how effective it is in neutralizing. So you actually have serum that's thrown into a plug neutralization assay, which is a plate where they have a monolayer of cells and viruses, and they do try to see if they can actually block the virus or infecting the cells. So in this case, the higher it is, the more effective the blocking. The lower it is, the less effective. And there is a line which determines how effective it is. If it's above this line, you are effective in blocking the virus. So we call that the level of protection needed. So immediately, you can see that with 2 doses of Pfizer-BioNTech, it works very well against the ancestral virus. It doesn't work very well against the Omicron virus, but it works well against the beta viruses with 2 doses. If you go for 3 doses, what happens is all 4 strains, the ancestral, the Omicron, the beta, and the delta, well, you have enough neutralizing antibodies to block them off. This tells you that it is effective. Again, this illustrates to you how antibodies are used to determine the effectiveness of the Omicron. Now I'm going to take you back to the beginning of 2020 when they first discovered the virus and they wanted to make an antibody test to it. They only had the original ancestral strain. So they designed the anti-S according to the ancestral spike protein. And that was their first version of it. But you realize that the virus didn't stop there. The test kit design stopped there, but the virus kept mutating. We have Alpha that took us by storm. We had the Delta that went on, that took everybody, hit many people, and eventually Omicron came. Omicron came is hurting everybody. And you realize there's a little bit of a mismatch, actually quite a lot of mismatch between the ancestral strain as well as Omicron or whatever strain that comes thereafter. There's a quality issue. But if you look at the whole assay, I may not have the good quality matching, but the quantity matching could actually overcome this quality defect. Again, stress to you, there is a mismatch between the ancestral strain that's used in the current test versus the Omicron. But it is what it is. They can't be chasing and adapting each lateral flow test or each assay according to different variant. The variants are changing too fast. But we learn to cope with it because when you actually quantify the antibodies, you can try to predict how effective the person's antibodies is or the vaccine is in protecting the individual. Next question is how good and what protection levels are needed. This is a beautiful paper which is in preprint, which means it has not been peer approved yet, where they look at the amount of antibodies levels and try to use that to predict if a person is likely to fall sick from the Delta strain. I want to stress you, Delta strain versus not falling sick at all. So before they fall sick, you kind of measure the antibody levels. And in this paper, they showed that breakthrough cases do occur when the anti-S antibody levels were less than 500 units. And this was with the Roche kit. The Roche kit was less than 500, you are likely to fall sick from COVID-19 with the Delta strain. But if it's more than 500, you are less likely to fall sick. So the protection level is actually 500. Have it and you get protected. So for the Delta variant, Roche anti-S, you need to be more than 500 units per mil. Some of you may notice that I introduced BAU here, blocking antibody units, because the units per mil in the Roche kit represents their own units per mil. You need a standardization across them all, and the WHO has provided it in the form of BAU. If you use BAU as a unit, it's actually about 485. So 500 anti-S with the Roche reading, you have good protection. If you want to translate it to BAU, which is an international standard, it's about 485. I'm going to digress here a little bit because each report tends to show their own company's units. So in the case of Roche, it will show theirs as units per mil. But if you want to change it over to the WHO standard, you need to do a multiplication factor, which is 0.97. And a quick way of deciding if the test kit is a Roche kit or an Abbott kit, for example, you look at the reference. If this reference says that it's more than 0.8 as positive, then you are dealing with a Roche kit. But in the case of Abbott kit, if you see a report of more than 7.1 BAU as considered positive, then you know you're dealing with a Abbott Architect kit. Again, the conversion factor for the Abbott value in AU versus BAU can be done there, and the multiplication factor is 0.142. Now here is a neutralizing test which is frequently available and used in Singapore and many parts of the world. It's called the cPASS. It's by Genscript. So cPASS, unlike the other companies, have come forward and say a protective level was 80%. They based this on the Vietnamese cohort where they had measurements of antibodies by neutralizing done before the individual falls sick. So before they fall sick, they have a level, and then based on the level, they looked at who fell sick thereafter, and they realized a protective level is about 80%. So this figure, which I provided in the cartoon, tells you as long as it's more than 80%, you have good protection against the Delta strain. But that's the Delta strain. Omicron, we don't know. And similarly for the anti-S, which we talked about earlier on, what's the protection for Omicron? We do not know. I reckon it's going to be a little bit more than the current figures, but I can't give you any solid figures now. Quite a lot of information I'm going to share with you now, the summary slide on the protective antibody levels. If you want to look for protection against the Delta variant, it's more than 500 units for the Roche anti-S, and for the cPASS, you need to be more than 80%. Again, the protection level against Omicron is unknown, but you expect that higher figure is required. So you have a 2 times figure of this, I will be quite happy, and I think you should be okay to be protected against Omicron. Next, what is anti-N? N represents nucleocapsid. If you have anti-N, it means you have antibody against the nucleocapsid. But most of the vaccines that are used, especially in the Western world, like the mRNA of Pfizer and Moderna, the J&J as well as AstraZeneca adenovirus vector vaccines, or some of the protein-based vaccines like Novavax, for example, they don't use the nucleocapsid. So if you will be vaccinated with these, you do not produce antibodies against the anti-N. So they don't have a positive anti-N. If you do have a positive anti-N result, it suggests that you have been infected with COVID-19. So this is a very easy test which doctors like myself will use anti-N to decide if the person has been previously infected. And mind you, it can take 10 to 14 days or more, even 21 days for the anti-N antibodies to develop. But you also realize that some vaccines which uses the whole virus for vaccination. You have the Sinovac, Sinopharm, as well as the Covaxin from Bharat, which is from India. They throw the entire virus with the nucleocapsid protein inside, and in turn you could mount an antibody to it. So the anti-N could then represent the vaccine response, immunity to the vaccine that was introduced. So anti-N could mean infection or previous vaccination with inactivated vaccines like Sinovac, Sinopharm, or Covaxin. We've talked a lot about antibodies, but if you think of immunity just as antibodies alone, it is rather myopic, because the body has other cells that are very important. You still have the physical structure, and very importantly, they have the T cell. The T cell plays a prominent role in the severity of illness, especially infections which the body can be trained prior. So if I have good antibodies and I have good T cells, I can actually cope with COVID-19 infection very, very well. So here we have the B cell immunity. B cell represents the amount of antibodies that are formed. And I want to stress to you, 3 doses of the mRNA vaccines actually restores the immunity needed. So besides the B cells, you also have the T cells. the T cells are very, very important, and they're represented by the CD4, CD8 T cells, but also include the cytotoxic T cells, the helper cells, and the memory T cells. B cells are important because they're the first line of defense. If the virus tries to engage and go into your body, enters your body, the first line of defense is the amount of antibodies which you have. Whereas the T cells actually is a second line. After going through the antibodies, if it bursts through, then the T cells will then determine the severity of illness. If you have great T cells, it tells me that you're going to have a very mild illness or perhaps no symptoms at all. The B cells, unfortunately, is affected by mutations. There's a change in the spike protein, for example, then the B cells antibodies will not be very effective against it. And this is how the virus evades the immunity. In the case of T cell, it's actually less affected by mutation, which is great because with the very different variants that comes along, it may break through the B cells, but in turn your T cells can still recognize them. In fact, there are many recent studies which suggest that the mutational changes in the Omicron strains do not affect the T cells, and the T cells are still working. In short, B cell immunity determines if infection occurs, and the T cell immunity determines the severity of illness. So both have their roles and both are equally important. Many of you would now be asking, can I measure my T cells? If I have great T cells, then I can promise myself that I have a good immunity and I'm going to end up with mild disease of COVID-19. Well, it is not quite freely available. I put here a few pictures and a few words. The one on the left, Straits Times, it actually reports Singapore scientists who created a rapid test to measure the T cells reaction to COVID-19. It is great because immediately, not only do you measure the amount of antibodies, which is very easy to do, you can measure the T cells reaction and hence the immunity thereafter. I have a special mention of QIAGEN because QIAGEN was just FDA approved. It's a quantiferon SARS-CoV-2 test. Now, you may be familiar with quantiferon because the QIAGEN has the TB quantiferon test. Now it's actually quantiferon SARS-CoV-2 test. This will measure the T cells that are. Now, on the right hand side of the screen with the purple box, you'll notice that other companies are coming up with T cell detection for COVID-19. And right at the bottom, this is a T-Spot company. The T-Spot company is a quantiferon competitor, and they have come up with a T-Spot COVID test. I haven't seen the approval in FDA, but I eagerly await more of these tests being freely available. It will reassure all of us. Now, just to the summary slide, I want to stress to you the key to neutralizing the virus is predominantly anti-S. And companies have come up to measure them, and with Roche anti-S, there's a paper to suggest if you are more than 500, you are able to overcome the Delta strain. You get protection when it's more than 500. For the cPASS test, it's 80% as per the manufacturer's recommendations. But there's no more Delta, or there's hardly any Delta left. So what then is a protection? It will be the protection against Omicron. What level it is, we have no idea. So until new science comes up, we will then make another video and then we can actually introduce it to you. Remember this, antibody levels never stay the same. It waxes and wanes, comes and goes, comes and goes. So after a booster shot, for example, the levels will be very, very high, and thereafter it will fall with time, and then it will boost it up again, it goes up, and then it falls with time. You get infected, it goes up, it falls with time. It will wax and wane. Antibodies' nature is like this. You can't do anything about that. So just relying on antibody levels is kind of silly because you know it's going to fall with time. So what's important is actually the T cell arm of it. The T cell arm would predict the severity of illness. If my antibodies fall but I have good T cells, then I'm able to block off the infection and I may end up with asymptomatic or no symptoms at all. or very, very mild symptoms. And I'm very sure you've heard of individuals who had Omicron infection, but they had no symptoms, or they had the Delta and had no symptoms. That's the beauty of the T cells. Even though they broke through the B cell defense, the T cells will be fine. And this will in turn offer you prevention of hospitalization and prevention against death. This is what you and I want. Remember, the T cell tests are coming, and the interpretation thereafter will be a separate subject altogether. But when that becomes available, I hope to share this data with you. With that, we come to the end of the slides. I want to thank you for being a wonderful audience and watching the entire YouTube. If you have any questions, any comments, please put them below. We'll try to address them. The purpose of all this series of videos is to try to make science as simple as possible. In fact, give the power back to the people so you can interpret science for yourself. Thank you. Until the next video. Bye.